And let me now quickly just share my screen. Okay. All right. I think we're good to go. So I don't think myself and Tony need to introduce ourselves anymore because all of you that's here tonight have already met us in some form or other. Monash University recognizes that its Australian campuses are located on the unceded lands of the people of the Kulin Nations and pays its respects to their elders past and present. So just for your information then, both myself and Tony, there are email contacts there. It's the best way to get hold of us, simply because I teach and Tony is sort of retired as well. And this was just a slide I put in case someone could not find the Zoom link. Now I'm going to just go over. I'm not going to go on the Monash webs on the Moodle site. I think all of you are now more or less aware of the all the tabs that's there. The overall one that you would use a lot is the unit information, and that's where you will have the timetable. And if there's any changes to the timetable, we will date it when we make the changes, and we will also put out an announcement as well. And then there's, of course, also the assessments, but I will be going through that. So those are the main stuff that you would be interested in. Under learning, as you are aware, we release the material on a week-by-week basis. So you would only see, if you open up learning, you would see getting started, which was last week's orientation, and then this week of week 1. And then under the assessments, that's where you will have all of your assessments, and there you can also see the dates as well as when those assessments take place. The forums, myself and Tony, we use that a lot to communicate to you. But you can also use those forums to post questions. But as I said last night, if you post any questions on the forums, please email myself and Tony because we don't always keep an eye on it, so that we can respond as soon as possible. And then just the support one, that's where there's links to for example, if you need to apply for special consideration, or if you want to look at what the library has, so that is all of the support stuff. And then, of course, on the left-hand side, this is my left-hand side, there's a drop-down menu of where you can just quickly scroll down to the weeks that you want to see. Any questions around that? You all good with that? Okay. And this is just then a link to the overall course. So the grad cert and the code M4020, and it gives you an overall idea of how the whole course has been shaped. And that's actually where the 4 units flow from. And then now specific to this unit, RAD5108. So this unit is then focusing on the upper limbs and also on the cervical spine. So it's upper limbs, including the shoulder and the cervical spine. So that is the key body parts of body areas that we will be focusing on in this unit. And I've given you a link to the RAD5108 learning outcomes as well as also the university's page, so that you can have a look at the learning outcomes as well as the assessments as well. Now, the resources, your main resource will be the Moodle site, of course, and check the Moodle site regularly. And also check the weekly timetable, because the timetable that's there, that's how we release the material. We release it on a week-by-week basis, and that is to just space your learning throughout the semester. And with some of those activities, there might be practice banks, but there can also be some before exams, for example. We could also have some formative tests as well. And then on the Moodle site, you'll have access to the image interpretation manual. What we normally do with that manual, it's quite a large document, as we would tell you on a week by week basis which pages we're looking at for that week. But you're most welcome to download the manual as a whole if you want to. And then in our Moodle books, we include everything there. We include PowerPoint presentations and also the reading list. So the reading books that we use for those weeks, we normally use ebooks, and we would link that to the pages where we want you to actually go and read up on the ebooks. Now, to support you with your study, we have catch-up tutorials, and the first one will be on the 30th of April, and the second one will be on the 27th of May. That 27th of May is the last teaching week, so it's basically week 12. And the reason for those catch-up tutorials is for you to ask any questions. So if there's something specific that you want us to address, you can always email us before the time. And those catch-up sessions will also start at 6:30 p.m. in the evening via Zoom. And then before the big exam, which you will write for this unit on the 26th of May, there will be a formative test for that one. But we also have a midweek formative test to break up the material, because there's only one exam which will cover all the work. So at least you can focus then on half of the material, and then on the second half again on the 26th of May. So image manipulation software, so it has the same capabilities more or less than what you use in clinical practice. So you can zoom in, you can do the windowing, you can do some measurements as well. And we use that software in our ISAP cases. We use it for the formative tests, but we also use it in the final exam as well. So you will have access to the software while you write your exam. There is a demo of the software if you haven't used it before, so most welcome to use that. For the exam, there will be specific login details, so you won't be able to access the software without acquiring the username and password for that software during the exam. Tony, you want to talk about this, the collective minds? You did talk about it last night, but maybe just briefly talk about it again.
Sure, yeah, I will. And there's also mention of Ian Cowan's site as well down there.
Yeah.
Collective Minds Radiology is it's an international internet site where you can register for free, doesn't cost you anything, and you can go in and have a look at all sorts of different cases. What it invites people, Collective Minds invites people to submit cases, maybe cases that they've found particularly difficult in reporting, or maybe cases that they feel that they actually did particularly well and got the right answer. And they want to just see whether anybody else is as good as them, I guess, way of bragging. But it's not just for us as, postgraduate course people. It's actually for reporting radiographers and radiologists and anybody else who wants to join. So there's a lot of different people get onto Collective Minds, put cases up, and then they contribute their opinions, and you can do the same. You can get on there and you can have a bit of a go, or not. You might just want to look at the cases. So there's a link there where you can get on to Collective Minds, and there's also a sample case link. This PowerPoint presentation will appear on your Moodle book after tonight, so you'll be able to get on there and just click on those links and just go straight to those sites. The one down the bottom there, Dr. Ian Cowan, Ian Cowan's X-rays. I'll refer to this occasionally during my lectures because I've I learn a lot from Ian Cowan myself. I worked with him teaching a course some years ago, and he after we'd taught the course, he went away and actually produced a website using a lot of the course content that we developed, and that website is particularly aimed at supporting radiographers who are interpreting X-rays, and it's mostly targeting radiographers in developing countries, but of course we can make use of it as well. So there's a lot of good stuff on that website, very logically put and well structured. Ian's a really good teacher, so I think it's worthwhile actually visiting that site at some stage as well. I'll just leave it there if you like, Imelda.
Okay, thanks, Tony. Okay, so this slide is probably the one that you are most interested in. So these will be your assessments. There's 3 assessments. One of those is an ISAP case. And then the second one is that exam that will take place at the end of the semester. And then there is a clinical portfolio. So we'll introduce you to those assessments separately as they come up as well. So the ISAP case has a value of 30%. We explained last night to the others about the CAP and the CR report, that there's 2 parts to it. And Joanne, I know you know how the ISAP cases work. So the deadline for that, the first CAP report is, the deadline is the 4th of April. And then the CR report a week later will be on the 11th of April. Now, the ISAP case doesn't have a competency hurdle. Doesn't mean you don't have to put any effort into it because the weighting is quite big. So there's a 30% weighting on that ISAP case. But if you don't get 50%, it doesn't mean that you will fail because of that. It will just bring down your average for this unit. But I would still encourage you, because it is a learning skill that you're going to work through, to put everything into the ISAP case. And then the exam is the next assessment due. That's 40%. And it has a competency hurdle, so it means you must pass that exam. If you fail it the first time, you can redo the exam, but that will be capped at 50%. And that will take place on the 9th of June, and I'll talk a little bit more about the exam as well. And then the duration for the exam is 100 minutes, and you can see the many weeks that will be covered for that exam. So there's quite a lot of material that you have to study for that exam. And then the third task will be a clinical portfolio, and that weighting is 30%, and that's also a competency hurdle. The deadline for that is the 23rd of June. So it's the last assessment that you're going to do, but you need to start collecting your cases for the clinical portfolio because you need to write up, and there's quite a bit that you need to do. Now, I will also give an introduction about the clinical portfolio itself because it's different requirements for the clinical portfolio. And then just a reminder again about the academic integrity material. If you haven't done it, and I'm not sure whether any of you have received any emails around this compulsory unit, but if you receive that email, I would encourage you to complete it as soon as possible, because if you don't, you might find yourself locked out of Moodle. And that academic integrity module is around plagiarism, collusion, and cheating. So artificial intelligence, the university supports this now, and on the Moodle sites, the one that I showed you where there is support, there is a drop-down menu called Learn HQ, and there's a lot of information around how to use artificial intelligence and the responsible use of that as well, and how to write it up should you use it for any assessments. Now, for this unit, all of our assessments, the summative assessments, all 3, you can't use AI because we're testing your skills. We don't want to test a machine, how well the machine does. It's your skills that we need to see and that you must demonstrate. And you need to do those tasks independently. Now, with special considerations, there's two types. There is a short extension, so you can apply for 2 calendar days. So if you find, for example, you a day or two before you say need to submit the ISAP case, you can apply for a short extension, and that will give you 2 calendar days. It means if an assessment is on a Friday, the next deadline will now be on a Sunday. So that is when you experience any issues. However, if you need more time, that's where you have to complete a full special consideration where you will need supporting documentation. And under the support tab, this is where you will find the short extension and special consideration as well. Now, with task 1, the ISAP case, this is going to focus on the cervical spine and the clinical action plan. So the overall word count for the ISAP case is 2,000. The clinical action plan makes up the most of the work that you need to do, and it's 1,500 words. So the university has a leeway of 10%. It means that if you have a 1,500 word restriction, then you can have 10% more, 10% less. It is to avoid students to just go overboard and to try and keep you focused on the main things as well. Now, as postgrad students, you only allowed 1 submission. When you submit either your CAP or your CR report, it goes through the integrated Turnitin software, and that is to check for any plagiarism against any other students' work or any published work as well. So, and it will give you a similarity index, and the similarity index is capped at 15% for the faculty. But what I always say is don't go into panic mode when you see it's more than 15%. We go in and we will check and see whether there's any evidence of cheating. And normally postgrad students, very seldom we find that they would have to be reported because of plagiarism issues. On the assessment tab, you will see the drop boxes for both the CAP and also the comparative report. Important to remember, when you submit your CAP report, it's only then that you will get access to the experts report, but also only after the deadline. So you won't get the experts report before the 4th of April, 5 to 12. It will become available basically at 5th of April, 0 hours. So it won't be available up till then. And then you've got to submit, once you get the experts report, you've got to compare and contrast it against your CAP report and then write up a summary of the comparative reports. And that comparative report, you can make bullet points of it. You can try and keep it as short, as sweet as you can. But we want to see evidence that you look at your strengths when you compare it, but also some of the areas that can be improved as well. And also one of the main things we want to look at is how can you use that information that you've learned through the ISAP case in your clinical setting. Now, the ISAP Moodle book will become available next week, so you'll be able to see what's required and all the scenarios in that Moodle book. And then just the submission dates then, the CAP is on the 4th of April and the CR report is on the 11th of April. So the online exam, all the resources that you use throughout this semester, all the Moodle books will be resource for you. The image interpretation manual, so all the materials delivered from 2, 3, 4, 6, 7, 8, 9, 10, and 11. The week 5 is the week where you actually submit your CAP report, and we don't deliver any new material during that week. The formative test then will be during week 8, and the other one will be in week 12. And as I said, those tests actually mirror the types of exams and questions that you can get in the final exam. and I also provide video recorded feedback on the formative tests. So if there's anything when you undertake the test, you can always feel free to contact either myself or Tony if you want more clarification about any of those questions. The exams are run via Moodle, so it's computer-based exams. You'll have the image manipulation software for that, and as already mentioned, that exam will be on the 9th of June. You can undertake the exam anytime from 8 in the morning till 8 in the evening, but make sure that you submit your work before 8 p.m. because the exam just shuts down at 8 p.m. But once you log on for the exam, irrespective of what time you start, you will just have 100 minutes to complete the exam. I usually encourage students to try and take some time off on the day when they do the exam, either half day or a full day, just so that they can get their minds ready for the exam. But it is a long exam. It's very taxing to write for so long and to remember so much material that's being delivered. So in terms of exam monitoring, there's an academic integrity statement that you have to accept at the start of the exam. And of course, as postgrad students, we don't expect any cheating to go on while you're writing the exam. And then what I normally do is I send an email before the time or I post a notification asking students to let me know what time they're going to start. And it's really important for me because I try to be at my computer in case a student runs into any trouble, because there could be things like where the internet drops off and to try and get them back again where they struggle. And then also then if they have any issues, I can extend exam time for that specific student. So it's important that you let me know your suggested start time. I normally send the passwords and the login details to both the exam on Moodle as well as the software about an hour before the time. But once I send that, so you don't have to start, if you said I'm going to start at 10 and something happens, at least it gives me an idea of to be around during that time. Now, the clinical portfolio, I have a presentation for that. It is a competency hurdle, and all of the material that you will need will be here under week 1. So I think for this one, I am just going to leave the clinical portfolio for the introduction around the clinical portfolio. I think there's more info there. And then also there's 2 parts to the clinical portfolio. So with the 1 part, you have to collect 25 clinical cases, and it must, of course, be of the body regions that's linked to this unit. And then you write up each case. Basically, you write up your preliminary evaluation of the case and then compare it to the radiologist's case. And then the second part is what we call a self-auditing, a preliminary image evaluation. And from what you've written up, you then calculate sensitivity, specificity, and accuracy, and then reflect on your personal, basically, image interpretation evaluation. But as I said, I will cover more in the intro to the clinical portfolio. Yeah, so I think in the clinical portfolio, I also talk more about the self-auditing PIE. I think the one main thing that's really important as you collect cases for the clinical portfolio is also to collect normal cases as well. Student tends to just focus on the abnormal, but remember, it's an important skill also to look at an image and to exclude any abnormality and say that this is a normal case. And if you have too few normal cases normally, that will affect your specificity as well. And I've just given you an example of how to write it up. So for this one, number each of your cases, identify the body region. If you have a case where there's more than one body region, say, for example, you have a shoulder, And for write it up as two separate cases because students get very confused about how to assign their specificity and sensitivity around a double case. Now, I will talk you through this as well in the clinical portfolio. So basically, that is the main thing. The important thing is to try and stay on task because it can become very daunting, if you take a couple of weeks and you do nothing to suddenly come back again because there's a lot of material that we present over those weeks. So I'm just going to stop share there and ask if there's any questions. Joanne? Did you have a question? We can't hear you. Your mute is on.
Yeah, okay. I was just wondering, we have routine views and special views or modified views. So for the body region, do you have any limitations as to what kind of projections we can collect for each region?
Yeah, so for each case, a minimum of one. Okay, you can add more images to that case as well, but put in, so if it's an abnormality and there's quite a couple of projections that was done, try and put in the most relevant ones, but you can add more than one. But you must at least have one image for each case, and it must be de-identified.
Okay, and then because there are some limitations to our access to the machine DICOM, is it okay if we take photos of the image of the screen? That means it's not a JPEG. Sorry, it's not a DICOM kind of
ICOM, it can be
image. Yeah,
JPEG.
yeah.
Yeah, so you can upload a JPEG image.
Okay.
Yeah. All right.
Sometimes, Joanne, the hospitals have rules around what you're allowed to do with images. So just be careful that you're not
Yeah, yeah. So I
breaching
have
any.
to just crop away the identifiers.
Yeah, yeah.
Mm,
So make sure that you check with your supervisors,
Yeah.
that you are able to do that. The majority of our students don't have an issue, but I know there was one student that in the end had to withdraw because he could not get, they didn't want to give him access to any images whatsoever. So in the end, he had to withdraw from the course. So it's a good point, Tony, just to make sure that, with the privacy rules around imaging and so on, that you're on the right side of that and discuss it also with your supervisors. The main thing is that the images that you're going to use will be de-identified. Also, when you write it up, you don't include any personal details of the patient as well. So, those are the main things that you can mention. It's not breaching any of the overall policy around privacy. I
okay.
just think someone just joined us
Yeah.
now.
We have an additional
Saskia.
student, Saskia, and she's asked a question about the fact that she's a paramedic and doesn't have access to images. And we've dealt with that before, haven't we? So,
Yeah.
Saskia, do you want to put your mic and maybe your camera on as well so we can see you? Or maybe not. Hi.
Hi. Hi.
Oh, there you are.
Hi, sorry. So I'm a paramedic, but I'm actually um living in London, living and working in London.
Okay.
And we don't have access to any images. We're not allowed to follow up with our patients. It's very strict here because we've got to get in and get out basically.
Yeah.
How am I supposed to collect the images for my portfolio? If not, then I might have to
Yeah.
drop out the course.
We
Tony,
haven't
I
we
hope you
haven't
heard because I couldn't actually hear it. It came very broken on my side. I couldn't hear the question. Can you maybe answer?
yeah. So Saskia is saying that she's a paramedic living and working in London. So an enormous number of patients. And the idea is, I mean, it's not dissimilar in Australia either. You get in with the patient, you drop them and you get out. And follow-up is actually not generally permitted. And so she has difficulty in actually getting images. Now, one of the things that we've maybe suggested before, and I must admit, Saskia, we haven't had a paramedic from London do the course, but we have had paramedics do the course, and we've suggested that they try to make contact with a radiographer who might be actually able to help them, and to sort of form a little bit of a friendship there. And don't know how feasible that is. You might even know of someone outside of the working world that you're in that you could actually contact, and even to use. I mean, I think it's okay if you can get access to like a database of images. I have one myself, but I think we'll have to sort of work through it. I think, Saskia, and sort of figure out a way to work around your problem, which we appreciate, I guess, is the important thing. We have had people in similar situations. We appreciate the problem, but maybe what we'll have to do is we'll have to work with you, stay in touch with you, and see how we can actually make sure that you've got access to some images, and also the report as well is an important part of it as well, is to have a valid report. It's tricky though in your case. Appreciate that. Have you got any other thoughts, Imelda, on it that I might
Yeah,
not
I
have
just wanted
stated
to
there?
ask Saskia, is there one of the NHS trusts that you regularly go and actually deliver patients to? Because quite often you work in a geographic area, because that might be useful, if you know that you're in London, so there's quite a few big hospitals there. And also to try and approach maybe the radiology department, because that might be a way. They might have a bank that you could access, which is available, not just to the radiology department. So you might be able to try and see if you can't speak to them, and maybe find out whether you can explain what you're doing and why you're actually doing it as well. I normally find, I worked in the UK myself, and I find that people are very approachable. So try that as an avenue, but if you really struggle, get back to myself and Tony, and we'll try and work around it.
Amazing. Thank you.
Okay. All right. Any questions from Madeline or William? You're all good. All right. So I just want to stop the recording. I can go on because I think I did do a special recording for the clinical portfolio. So I'll just go over that now and just share my screen again. So Saskia, so you joined us a little bit late. If you want to stay behind, I can just quickly go over the little bits, especially how to find yourself in the Moodle site, and how to go around if you maybe want a little bit more support around that. Okay. Because we've already done it with the others. So if there's anything that you want me to show you, I can do that after we finish.
Okay. Thank you.
All right.
There's a recording available of the whole session as well, Saskia. So that'll be available from tomorrow, I guess.
I normally try and finish it
Tomorrow
off in the
morning.
evening. So, sorry, Saskia, I just wanted to ask you, are you just enrolled in this unit, or did you enroll in any other units?
So I'm doing the critical care, but they've got an elective semester. Yep, so I'm doing this and an aeromedical as an elective.
Okay, Tony, I didn't, for some reason, it just goes very muffled. What did she say? Which unit is it?
Yeah, I guess you're having to pick up patients with fractures on occasion, Saskia, and so it would be good to know a little bit more about them. And look, I think what we've found with having, I mean, we've had paramedics, physios, doctors, who are nurses and nurse practitioners doing the course, as well as lots of radiographers. And often I think we can learn from one another. So, you know, you've got a lot of knowledge as a paramedic, particularly, you know, in frontline first responder type situations that maybe, you know, a lot of us radiographers that don't actually necessarily have that knowledge because we're not first responders. You know, we're there at the hospitals and also in the private practices and primary care facilities and what have you that that we may be, you know, so your clinical assessment of patients on the ground, on the spot, when they're injured is actually important stuff. And look, I'll say to you radiographers out there, and this is still being recorded. So yeah, if you can please think about that and expand your mind to think outside the radiology department. I'm a big one on that for radiographers to actually think beyond just performing the X-ray examination and looking at the images. You really need to think about what's going on around that patient, how they actually were delivered to you in the hospital or primary care facility or whatever it is, and also what their situation might be, you know, sociologically, because those sorts of things also affect the well-being of the patient, the health and well-being of the patient. So I think, you know, this course, your postgraduate students, you know, this is an opportunity to actually expand your mind and actually think a little bit more broadly, not just think, you know, we do tend to be as radiology staff, radiographers and radiologists, you know, I think traditionally we're sort of inside concrete walls, often with the lights down. And it's good to actually sometimes be able to get your mind outside that space and into the broader world of the patient and other health professionals like Saskia. And Saskia gets a bit of, well, she get a lot more insight into what we do as imaging people, and I think that's always a good thing. The interprofessional collaboration and communication is just so important. Yeah. Okay. I'll
All
be
right.
quiet about that.
Okay, thanks for that, Tony. So I'm just going to go over the clinical portfolio. Okay, so don't need to introduce ourselves. So for the clinical portfolio, all of the information will be found under this week, the first week of March. So in the Moodle book, there's a number of Word documents that I've put together to assist you in how you can go about accumulating your cases, but also then when you need to submit your clinical portfolio as well. I've also made a video recording of the introduction of this session so that you can just go over that if you need to. Quite often students don't actually think about this. They start thinking about it sort of in the middle of the semester, and then they can just refresh their minds for it. So as I mentioned, there's two parts to the clinical portfolio. So you need to collect a minimum of 25 clinical cases, and that will include, of course, the cervical spine, the shoulder, and the upper limb. And then you've also got the second part is a self-auditing PIE record, and that is actually to determine how accurate you've been with your preliminary image evaluation. And the deadline for that is the 23rd of June. So the deadline looks quite far away, but you have to start collecting your cases systematically over the semester. So with the cases, your 25 cases, each case is worth 4 marks. So the total marks for that part of the assessment is 100. The overall word count for the clinical case is 2,000, and it works out roughly to about 80 words per case. But I usually say to students, don't stress. Some of the cases you'll write less, some you'll write more. Because students who normally say, oh, I can't get my words in just with 80 words. It's possible. But yeah, so there is a 2,000 word count for that. And then, of course, the only cases you need to include will be from the cervical spine, shoulder girdle, and the upper limbs. Now, when you write up your cases, you can use a reference if you want to really support one of your statements that you're making, but it is not a requirement. And then the use of generative AI is not allowed because you need to write that up yourself. So in the information that you need to provide for each case could be the mechanism of injury or maybe any clinical signs and symptoms. And then, as already mentioned, you need to provide at least one de-identified image. You can add more images to support that case. And then you write it up as a preliminary image evaluation. So a short and succinct, if I could say, comment about the case itself. And then you compare to the radiologist's report. Now, one thing that you need to remember is normally when you look at a radiologist's report, it can be quite verbose. They write a lot. So say, for example, if the patient is a cervical spine case and query fracture, it's a trauma case, but then they might still mention some osteoarthritic changes. So when you compare your PIE to the radiologist's report, focus only on the clinical question. So if the question was about trauma and the radiologist adds, some chronic stuff, you can ignore that part of the report. So only compare yourself to the relevant things that's in the radiologist's report. However, sometimes you can actually find that even if it's trauma, there might be a pickup of other pathology that's really important. So you need to keep that in mind. So say, for example, if a patient comes and then they see something that looks a bit more sinister, and it could be the first time that they saw a lesion in the bone, which could maybe mean something like either metastasis or a primary tumor, and you have to pick up on that then. You can mention patient management, but you don't have to. So, but if there is a case that really interested you and how it was managed, you can actually add that as well, but it's not a requirement. So the marking rubric looks like this more or less. So the patient's presenting symptoms, and then your description. So when you describe what you see, you can link it to the ABC search strategy. Now, I'm not sure how much you guys know about the ABC search strategy. I would assume, Saskia, you don't know much about it. But basically, with the ABC search strategy, it's a way of systematically looking at an image so that you don't miss any of the pathology. And we will have some of those information coming up probably next. I think it's in this week, if I'm right. And then you compare, write your report, and then compare that to the radiologist's report, and then, of course, include the de-identified image. And as mentioned, each case is marked out of 4. And this is how you can write it up. So if you write it up like this, you can quite quickly write it up in just 80 words. Really important that you identify each case, because the reason for that is when you do your self-auditing PIE, students refer to that, and then I'm not sure which case they are referring to. So please number each of your cases. Make sure that you include the body region that you're talking about, and then the clinical indication. of course, one de-identified image. So this is just an example of a preliminary image evaluation, and it's stated there's a comminuted fracture to the distal radius with dorsal displacement, and there's an associated ulnar styloid process fracture. And when compared to the radiologist's report, the key thing that was not mentioned is that this fracture is intra-articular. That is quite significant. You're then going to write up your case then in terms of whether it's a true positive. So true positive meaning that there is a pathology, and when it's true positive means you and the radiologist agree on the pathology. A true negative means the case is normal and you and the radiologists agree that the case is normal. And if it's false negative, so that's where you actually say the case is normal. It's like here you did not mention intra-articular, so that would be seen like a false negative as well. And in that case, you use fractions because each case can only be worth 1 mark. So when you add it up, if you have 25 cases, in the end, your total mark should be also 25. So then in your self-auditing record, the total marks for that is there will be a spreadsheet where you've got your 25 cases, and then you will have a column which body regions you're referring to, and then work out your true positive, true negative, false positive, or false negative. And as mentioned, you might have to assign fractions as well. So say, for example, if there's 2 fractures, you only identify one with the radiologist and the other one you have not identified. You will then assign half true positive and half a false negative for missing the other pathology. And then you calculate the following marks. So sensitivity is your ability to identify the abnormal cases. Specificity is the ability to identify the normal cases. And accuracy is combining your sensitivity and specificity, and it gives you an overall accuracy rate. And I give the formulas to work that out. And then the final part of the self-auditing record is where you provide a brief reflection on your abilities. And that reflection could be, for example, something like, I used to struggle a lot with identifying pathology on a shoulder, but during the course, it has really improved. Or you can say there's still an area, say, pediatric elbow, for example, where I still need to improve, for example, or even struggling with writing with terminology that you don't always use the correct terminology. And for that, that's 5 marks. So then allocating the true, negative, and so forth. Use your own judgment when you do that. So we are not prescriptive, but I normally look at, have you assigned it more or less correctly? And then you then summarize it in a proposed spreadsheet. And the spreadsheet looks like this. So you've got your body regions. You will add rows to it. So from the cervical spine and then the shoulder down to the fingers. And each case, when you write each case up, so if this is case 1, everything that's in here should add to 1. So in the end, if you have got 25 cases, if you add all the true positive, true negative, and so forth up in this row, that should also be equal to 25. So make sure that those calculations are correct. And that's why I say if you have got a case where there's 2 body regions, so say, for example, a shoulder and a humerus or something like that, write it rather up as separate cases, because students then get very confused about how to assign those fractions. This is just a 2x2 table where we have got the radiologist report, which is the gold standard, and you measure your PIE against the radiologist report. And basically, in terms of the positive findings, whether it's a true positive or a false positive, and then a true negative or a false negative. And I've just given you the formulas again. So the main thing with sensitivity and with all these stats is you want to be as close as possible to 100%. So with sensitivity, you want to pick up most of all of the abnormal. So you want to have as few false negatives. So false negatives when you miss those abnormals. And then with specificity, you also want that to keep that as close as possible to 100%. So you want to have as few as possible false positives where you overcall on your normal cases. Because when you do overcall, and it might apply to some of the radiographers working on their own, even though you might be working in a big hospital, for example, after hours, there's not a lot of radiologists around. Sometimes the referring physicians come to ask you, and you might say, okay, this is what I see. And if you give information that is not correct and they act on it, then there is a high risk. They might decide, okay, maybe we must do more diagnostic imaging for that, and the patient then gets more radiation. And then, as I mentioned, the accuracy ratio, that is your true positive and true negative results for all of those 25 cases. And that will give you an idea how accurate you are overall in terms of image interpretation. The one thing to remember then is you have to have a range of clinical cases. So you can't just have, say, cervical spine, and maybe you focus on knees and nothing, not knees, sorry, don't know why this thing went off. You focus maybe just on elbows. You've got to make sure that you try and cover the whole body regions. However, if you do have an issue with any of the body regions, also contact us, because we've had that as well, where someone worked in an area where they very seldom saw certain things. So please do contact us. Okay, so I'm going to stop share and just ask if there's any questions around the clinical portfolio. I think for Madeline and William, Joanne, did you do RAD5109 last semester?
5109 is what is the title?
5109 is the one that has got the pelvis and lower limbs. Did you do that one, or did you just do 4502?
Yeah, I only did the foundation.
Okay. All right. No, that's fine. So the clinical portfolio is new for you as well.
Yes.
Okay. So it will be new for all four of you that's here tonight. So really, if you have got issues with picking up any cases, just let us know. We work around the students. We want to make sure, that where you are, where you practice, that the information that you get here is relevant to your practice as well. So please do contact us if you struggle.
Imelda, just a quick question. I'm wondering about our way of writing, because sometimes assessors can be quite anal about, how we write, like query, do we spell out the whole word, or a question mark is enough? Fracture, sometimes they say, oh, a hash sign is good enough, but do we have to spell out the fractures word?
Are you asking if you can use abbreviations or
Yes.
yeah,
Yeah, common abbreviations.
yeah, common ones you can use, yeah.
Okay.
Okay.
Just wondering whether we can, just off the top of my mind, whether I can cut down on words.
Yeah, no, as I said, don't stress too much about the word count.
Okay.
But also, if it comes nearer the time of the clinical portfolio and you really struggle to write up, email me and just send me one of your cases that you've written up so that I can look and give you some advice as well. Because I've done that in the past where students really struggle to write it up.
Okay, thank you. That'll be really helpful.
Okay.
Can
yeah.
I just comment that one area in your clinical portfolio that you might have collecting cases on is cervical spine, because we just don't do many plain radiography of the cervical spine these days, but you may come across some. pretty rare. But I think see how you go. I guess if you can't, you can't. But because both, William and Madeline, for example, work at quite large hospitals, most of your cervical spine patients, well, they should go probably straight to CT. And you'll see that in this course, we sort of plunge straight into cervical spine first of all, because the ISAP case actually deals with a cervical spine injury scenario. Now, that's not because we believe that you need to know everything about plain radiography of the cervical spine, but I think it does feed your general knowledge about the management of patients and assessment of patients with injuries of all sorts, and not just cervical spine injuries, because we'll get you to have a close look at clinical decision rules and to actually make use of those, and the particular clinical decision rule algorithm that you'll be having a look at, and this comes into it next week in your lectures and things, actually takes you through the steps of making decisions about what imaging is appropriate, should the patients have particular signs, symptoms, or whatever, or mechanisms of injury. And basically it ends up that most patients should actually go straight to CT. So that's okay. We understand that. We're not maybe as silly as we might seem in that regard. But I think the general knowledge about cervical spines is actually quite useful, and actually feeds into your understanding of CT as well. And in fact, the ISAP case that you'll do is actually the patient actually ends up in CT anyway, so you've got some CT images to look at. Yeah, so it's all sort of logical in the end, even though maybe initially, next week, maybe the week after, you might wonder why you're doing all this cervical spine stuff. Well, it's not going to hurt you. And I think in the meantime, take advantage of getting your clinical portfolio stuff in order. And Saskia, you're going to actually communicate with us about your clinical portfolio and what you do about that. I was thinking while Imelda was talking about radiologist reports, in a lot of cases in the hospitals probably that you're delivering patients to, it'll be the radiographer's report, because there's a lot of radiographers who actually will be reporting in the UK. So it may be that if you can actually find one of those radiographers who are actually doing reporting, although they're probably just as busy as you are, you may actually find that they've got a sort of educational database that they might be able to give you access to, and they might be actually quite helpful if they appreciate the fact that he's a paramedic who's keen to actually know more about imaging and image interpretation. So yeah, I say that with my fingers crossed that that's actually going to be true for you.
Yeah.
Mm.
William, do you have any questions?
No, I don't. Thank you.
Does the clinical portfolio make sense?
Microphone, mate.
Yeah, sorry. You've explained it well. Thank you.
Okay. So as I said in the Moodle book, so there's a dedicated Moodle book for the clinical portfolio. There's some documentations there as well that will help you. Okay, thanks. And Madeline, are you okay now? Because I think the clinical portfolio is the only thing that we've added tonight for you that's new as well.
Yeah, the clinical portfolio is most definitely new. But that's okay. It's pretty well gone through majority of my questions, obviously. I'm trying to have an even-ish number amount of each of the region of interests.
Okay.
Just a quick note where we compare to the radiologist's report. So obviously you've got what the radiologist has stated, and then this is how I got it right or how I got it wrong. In your result for the true positive and false negative, where you have in brackets intra-articular not mentioned, do you obviously there want us to specify why we like marked ourselves down as such if you do miss something that is critical?
Yeah, so normally students will mention why they've assigned maybe a false negative, and they would say, I missed this. So because you are comparing your report to that of the radiologist, so in that comparison, you would write, I've identified the majority, however, I've missed this, so you into that comparison, you need to write it there.
Yep, okay.
One of the hazards is that radiologists are not always right. That you may find that when you're actually making a comparison with the radiologist's report, you don't agree with it. And this happens to us all on occasions. Probably that does make things a little bit difficult because we are saying, okay, well, the report is the gold standard, the assumption being that it's 100% correct, whereas in fact, we know that it's not 100% correct at all. In some studies, it's actually shown that in some regions of the body and some imaging types, radiologist reports can be wrong 30% of the time, which is, quite large. It's not usually that case on a day-to-day basis, but it can be of the order of sort of 5% or so that they actually miss things or, either get a false negative or a false positive themselves. I think if you I don't know how you feel about it, Imelda, but I think if you come across a situation where clearly, you're in disagreement with the radiologist and you don't know whether it's actually a true positive or a true negative, and how to judge yourself, then you possibly need to ditch that case.
Tony, can I maybe just follow up on that, because I've had a number of cases from students where they've actually picked up a pathology which the radiologist missed. So the best thing to do there is they've actually gone to a third person and then just to verify. And then also the one case that I think about now is actually one of our graduates who worked, it must have been near the ski fields or something, I think, after hours, and there was no radiologist there. And it was a pediatric patient. She took the x-ray, and because of the ABCs, when she drew those lines, because with children you can't always pick up immediately that there's a dislocation, so she could see there's a dislocated radial head. But what she did was she knew the doctor in the emergency department was a young doctor, and she went and actually asked, what did he think? He said, no, it's normal. And then she said, it's actually not normal. And she showed him the alignment. If you draw those lines that you need to draw the radiocapitellar line, that it was dislocated. So she immediately, and that is actually what our MRPBA expectation is. So that patient was then taken to theatre and managed appropriately. And then it was over a weekend. The Monday morning, the radiologist reported it, and she looked at the report, and the radiologist said it was normal. So she then went to the radiologist and also did the same thing, said, draw the lines. And the radiologist was actually very appreciative. He wrote an addendum to that report and mentioned the radiographer by name, and to say that he actually initially missed that. Now, not all radiologists will do that. However, if you do pick up and there is a discrepancy and you are right, make sure that you include the images so that I can see it as well. And then if you have an addendum to it, maybe a third person who reported it, you can include those cases. I've had actually quite, not a lot, but a few students who actually mentioned cases or wrote up cases where there was a discrepancy, and the discrepancy was not on their side. With those cases, it was on the radiologist side. And I just want to say, with general x-rays. Radiologists are now so used to looking at CT. They actually, I think they're starting to lose some of their skills with plain x-ray imaging. They just very used to looking at CT scans and ultrasound. So they actually wrote up a paper that they start to lose some of those skills. So just to mention, if there's a discrepancy, try and see whether you can justify it, why you think this is that. Either you have discussed it with another radiologist, or the radiologist wrote an addendum, or you include the images, so that I can see those images as well. I wouldn't ditch it. I would rather keep it in, because it shows that you have learned and you're using that knowledge in that particular case as well.
Yeah, so long as you just revise the gold standard and you make sure that gold standard, and often, going to the clinical side of things, going to the clinician, the doctor who treated the patient, and actually finding out what the end result, what the end decision was, is, the proper gold standard.
Yeah.
And yeah, so the other thing that I just wanted to mention, and just thinking about the way that radiologist roles are changing, is that AI is actually coming into the picture as well. So artificial intelligence in terms of scanning images, using AI. And although it's not out there sort of in every department, it is actually being used. And on that, mention that Collective Minds Radiology website, you'll actually see there some cases where AI has been used, and you'll get the AI report, and you can compare your own opinions on the image with the AI report. And it's interesting to note that AI is not right all the time either. And it's sort of a supplementary thing. But there's actually an article. I don't know how many of you are actually members of the of ASMET, of the Australian Society of Medical Imaging and Radiation Therapy. But if you are, you'll have actually got a copy of the Journal of Medical Radiation Science recently, and there's a bunch of articles in there. There's about 3 editorials about image interpretation. And one of them, I think it was Andrew Murphy, wrote about the use of AI and the way it's evolving. And I think it's a necessary thing that you sort of factor that in at some point in your thinking about where AI fits in. But one of the limitations of AI that is actually really important is the quality of the images. The adequacy of the image that is given to the computer to scan is actually critically important to whether or not AI actually gets the answer right or wrong, or maybe detect something that's actually not there, and it's actually just an unusual appearance because of the way of the positioning or positioning, I think in particular, can actually cause AI and your eyes as well to actually make a wrong call. It's really important, and I think I mentioned this last night as well when we were talking about 4502. It's really important to actually have a good quality image to start off with. The adequacy of the image is important to assess, even before you start looking at pathology. And so that's why there is something of an emphasis in all of the units in this course on like normal anatomy, radiographic evaluation criteria, making sure the positioning is done correctly and you can see the structures that you expect to see in the correct format. And just sort of trying to get the imaging correct is actually a good starting point. Well, it's an excellent starting point. It's more than a good starting point. It's a really essential starting point. to actually get the images correct and then actually have a look at them from the point of view of pathology. And then you sort of go through your A, B, C, S.
Yes.
But we'll talk about that during the course. So, yeah.
Yeah, it's interesting that you're picking up on AI. I just had a session this morning with the fourth years where they had to actually look at AI being used in diagnostic imaging. And there are a lot of benefits, especially on picking up on subtle things. But one of the students mentioned that in their practice, the radiologists use AI, but it's used as an additional resource. It's not the final report. So it's a similar, like when you, I don't know, if in some of your practices you write maybe a comment or preliminary image evaluation, they use that, but they still write the final report. So the AI at the moment in that practice is just used and as an additional support.
Yeah.
Yeah. Okay. Yeah. Any other questions? Because Saskia, I think you must just stay behind a bit. What time is it now in London? It must be about 10 or 11 hours behind, eh?
Yeah, roughly, I think.
Time for bed, is it?
No, behind.
Starting
It's
up,
morning.
starting for the day.
Oh,
Yeah.
sorry.
The day is starting.
Hmm.
All right, Joanne, Madeline, and William, do you have any questions? Okay, thank you very much. But listen, always feel free if you've got any questions to contact either myself or Tony. We're here to help and support you through this unit. So please don't feel isolated because you're not in a class with us and that you're somewhere just in front of a screen. We are here to help you. Okay, I'm going to stop the recording and then so that I can maybe just